Perfect. Thanks, Nathan. Okay, hopefully everybody managed to stretch their legs a little bit, grab a cuppa. I had a banana with my dog. Okay, right. I think we will crack on. So we are, again, my laptop is very unhappy about the new version of Teams. Okay, so we're on to item number 5. I'm going to invite Tim to speak to this item. So this is the Director of Public Health's annual report. We've seen a few of these and they're always thematic, which is a really nice way to look at things. It brings a different perspective and I think it's much appreciated. So I will hand it over to you, Tim, and you can take us through the highlights of this one.
Thank you very much, Sarah. And I'm delighted to present the the latest Public Health Annual Report. The report are, I suppose, historically about the health of the people in the population served by the director relating to the previous year. So the date on this is 2023, reflecting the health of the population of Highland and Argyll and Bute in 2023. As Sarah says, though, that we have adopted the idea of having themes, which I think is a helpful way of looking at different implications and associations of public health. And the theme for the report this year is around public health and medication, and I'll come to that in a little bit more detail in the presentation in a minute. Originally, I'd intended to call the report, or to subtitle the report, The Good, the Bad and the Ugly when it comes to medication. I was very reluctantly persuaded to change that with the view that it was style over substance. So I chose the idea of doing the right thing as a bit of a change, but for the presentation, as you'll see later, I've reverted to a bit more of the theme of the good, the bad and the ugly, because I think it's more memorable and when it comes to thinking about the implications for public health and medication. So if I can share my screen and move on to the presentation, which I hope everybody can see now. Okay.
Yeah, that's good.
Yeah, that's it. First of all, I would like to thank thank all the contributors, because it's certainly not my work in the rota particular introduction, but there's a far wider element which is included within the wide contributions list you'll be able to see in the report. But also a particular thanks to NHS Highland Medical Illustration, who stepped in at a very late stage when our normal graphic design capacity wasn't available and took over the design and production of the report. So thank you for them. The first section of the report covers diseases and overall health within the population of NHS Highland, both the Highland and Argyll and Bute areas. So I've included just a small number of slides to demonstrate some of the important themes. So this is overall life expectancy. Life expectancy is a slightly unusual statistic, but it gives a good idea of what's happening to people's to how long people are living. It's not a prediction of how long we live, but it's a collection of current lifespans all stuck together. But what it shows, as we well know, men live a little bit longer than women, and there has been an increase in life expectancy over the past few years, but it's stalled and to some extent dropped very slightly. But probably even more concerning than that is the increase in health inequalities that is evident, particularly in male life expectancy, with you see a big gap of almost 10 years between the most and least deprived 20% of the population. And move on to the next slide, and it's clearly not all about life expectancy. It's also around how long we live in good health and how long we live in poor health. And this slide compares NHS Highland with Scotland. We see that we live whole life expectancy slightly longer than the Scottish average, and actually years in poor health is shorter. So we're doing quite well in that regard, but there's still over 16 years in which on average women are in poor health, and over 14 years that men are in poor health, and that's very considerable length of time. And the picture is even more dramatic when we look at people who are at the poor end of society, more socioeconomically deprived, who have a real long time in poor health. And these are the type of things that make up that poor health, adjusted for disability. And it's essentially it's about the best we can do to work out what diseases contribute to disability and contribute to that poor health shown on the previous slide. So there's a lot around ischemic heart disease and strokes, cerebrovascular disease, dementias is quite important as we come towards the end of life, and then various cancers. So a wide range of conditions. But heart disease, dementia, and cancer is particularly prominent. And again, if we look at health inequalities, this is quite stark. I'm sorry that the slide's a little bit busy, but it's mainly to illustrate the theme more than anything, and that we can see for a range of important conditions, whether coronary heart disease or young people's deaths, suicide, and particularly when it comes to drug-related deaths, there's a really dramatic feature of health inequalities. And the poorer you are, the worse experience that you'll have, and the more likely people are to die early. So that is just a very brief summary of the overall sense of public health in the local area, which is set out in the report. So if you move on now to looking at the particular theme, which is medication and public health, which brings together various themes of the work of the public health department, as well as things that perhaps we haven't done yet, but really need to concentrate on and look at in the future. I'm afraid I couldn't actually get by without putting that slide up, just as a reminder for people. But to look more seriously, so we're looking at the good, the bad, the ugly, the alternatives, and also bringing stuff together. Not all is good, not all is bad or ugly, that there's the opportunity to bring things together. So this, although in a slightly different order, this is the order of the way that the report is actually structured, shows the different elements and what we have concentrated on in the report. So each of these represents a chapter which looks at a different aspect of medication and public health, some good, some bad. So to focus on the good first, hepatitis C. It's a bloodborne disease transmitted similarly to hepatitis B and HIV, which are probably a bit better known, not quite as infective, but pretty common and pretty serious. And there's a drive in the UK, particularly in Scotland, to eliminate the condition. There is an issue with diagnosis, and lots of people will still have hepatitis C but not know about it, and there's a need to raise awareness. But the particular thing about putting it in the report this year is that one of the developments over the last 5 to 10 years probably is a rise in medication that is easy to take, has few side effects, and can eliminate, in most cases, hepatitis C. So say over 10 years ago, the treatment wasn't very good and had lots of side effects of taking intravenous interferon, and it would put people off getting treatment. But the new message is that there is effective tablets that can get rid of Hep C. So it's really important that people who may have been exposed to Hep C can get tested, and we can actually look at eliminating the virus. So this is good news: a medication, effective and well tolerated, that can really fulfill a public health good. If we go on to something not so good around pharmaceuticals and medicines that are in the water, and medicine causing pollution, and NHS Highland is a very considerable leader in this area. And there's been a lot of work done particularly through Sharon Flager in the Public Health Department, and also with colleagues in CPER and in UHI, to look at what we can do in the local area to establish what levels of medicines are in effluent, and to deal with them. And it's part of effective prescribing, minimising prescribing, disposing of medicines in a good and appropriate way. So there's a lot more in terms of details and links within the report. The next one, the slide is on drug-related deaths. The chapter includes that, but is around medication and using medication for pain, and how that potentially clearly can be a very good thing, but also potentially cannot be good, in that sometimes pain medication is carried on for a very long time, when people would actually be better having other forms of treatment. And pain medication can also be used, can become addictive, either addicted by the people it was prescribed to, or addicted by other people who are addicted to the medication and want to use the medication can get it from those prescribed it. So there's a large hidden challenge to us and problem of prescribed medication for pain, which isn't actually doing the job it was intended to do. So this is an area that we haven't explored really deeply within NHS Highland, but is something that I recommend that we look further at, and try to get a more rational and appropriate approach for everybody to pain medication prescription. But the background to that is the continued rise in drug-related deaths within Highland. Now, these very often relate to illicit drugs that people buy and use, but when it comes to drug-related deaths, most drug-related deaths are caused by a range of different substances that people have taken at the same time. There's also a chapter on social prescribing as an alternative to medication, that various things that can be done, whether through primary care or secondary care or social care, where people can be directed to alternative interventions. Perhaps prescribing overly medicalises it, but in the context of alternatives to medication, it may be appropriate. That various initiatives can be used to improve people's physical health and people's mental health that don't include medication. But the final chapter in the report is a couple of case studies where we look at how both medication and also other interventions that aren't medication can be brought together to improve people's health. As ever, there are quite a few recommendations within the report. I've tried to make them smart, specific and measurable, etc., so that they can actually be used appropriately, and that we can actually look in the future and come back next year and see how they have been addressed. And with that in mind as well, conscious of the mention both of health inequalities and prevention in the board meeting this morning, there is also a very short section in the report on how the recommendations from last year's report, which was themed on prevention, have been enacted. Some more recommendations, and that's the end of the presentation. So I'm quite happy, very happy to take any comments or questions.
Thank you, Tim. So I really enjoyed reading the report, and I hope members had time to read it in full. It's a really stimulating piece and lots to think about. I've certainly got a question or two that I want to pick up, but I will open it up to the floor and take other questions first. But I'll bring you in, please.
Thank you, Chair. Thank you, Tim, for your work on this report. A very interesting read. I just have got one question. It's in relation to the progress on the recommendations from the 2022 report, which I think are outlined in page 15 of the document. I'm just wondering if what you've told us there takes account of all of the recommendations that were made. In other words, has everything been taken forward, or were there other recommendations that haven't been taken forward that you haven't mentioned here? Thank you.
Yes, it's more. I haven't gone point by point on the recommendations and look in great detail. The idea was to try and really get a summary of where things have been taken forward. So I think the progress, I think, is not. It certainly isn't set out as in detail as it could be, and some of the work is going to take a lot longer to be able to get significant progress and quantifiable progress. So what certainly isn't there is what we would look for in more quantifiable progress, and saying we have achieved these definitive targets. And recommendations were they would be amenable to putting numbers and clear progress on, but I think it's probably a little bit early to do that. So what I've tried to do is to put some general markers around progress, but to get proper knowledge of progress, I think we'd need to look further in the future. So I think that's something we need to develop, and how the recommendations are monitored more precisely in future. So I think it's certainly a fair point.
Thanks, Tim. Emily, I'll bring you in next, please.
Thanks, Sarah. Thank you, Tim, for the report. It was a very similar question to Bert's, actually, that I had around the monitoring of these recommendations. They, in the abstract, they seem sensible. I was just wondering, how do we track progress with their implementation between these annual reports, and what kind of touch points do we have to see how things are going?
Yeah, I think I mean, some of that I've already covered in that I mean, a lot of the recommendations are not precise. I think the challenge for a public health report is that the public health reports are independent reports. So I make recommendations. They're not recommendations that they are, and I suppose I hold myself to some extent to account, but also I recommend the role of a director of public health in whatever organisation is slightly complex, in that the report is independent, but I'm an executive director of the board. I'm not making these recommendations on behalf of the board. These are to some extent independent recommendations. So by that very nature, then they're probably not going to be really precise, because it's something around looking for partner organisations, well, the board and other partners, to prioritise these. So I will come back and look at what's been done, and getting quantitative information about what's been done is certainly important, as I was saying to Bert's question. But it's not probably about setting specific goals, because it's not really within the remit to set those goals. It's the remit to recommend that other organisations prioritise things and will set goals. So where I can look in future and see this has been done or this hasn't been done is possible, but it's a little bit vaguer. But I think there's certainly scope for being clearer on the quantitative side. Now, of course, any organisation can say, well, yes, we note what you're saying, but actually that's not our priorities, and we're not choosing to implement them. So that it's not, I can't hold other organisations to account for recommendations, because it's up to the organisations and up to the board, of which I am a director, to decide what we want to do. So there's a little bit of nuances there, and I think we probably haven't got it quite right at the moment, but that's sort of the background to how the recommendations can be made, and then can be monitored in a general sense. But what I think is important is that the recommendations from previous reports are considered, and that we do go back and look. So I don't think we got it quite right this time, or even last time, but I think that a report without looking back at previous recommendations would be inadequate.
Thanks, Tim. And thanks, Emily. It's a really, really good question. And actually, I think there's a little bit in there about how do we as a board and how do we as non-execs take the points in that report to help us shape our scrutiny, and how, what we're looking for, because, a lot of that stuff will be cross-cutting and will sit kind of across lots of different pieces of work. And I think actually I find these reports helpful because it gives me something to take away, and I can then frame questions around different areas of performance through that lens. And I think that's quite a helpful way to use the recommendations in these reports as well. Okay, sorry, Emily, did you want to come back in on that?
Sorry, yes, just saying that the question might have been directed at the wrong person, but I think that the broader point of how do we as a board get comfortable that we're making progress against those recommendations, I think we should take away.
Yeah, no, I think that's a good point. Okay, I've got Jerry and then Karen. So Jerry, I'll bring you in next, please.
Thank you, Sarah. My actual question may well be an extension of what we've just spoken about, and it may well already have been asked and answered. But we mean, firstly, just to thank Tim, as always, for his annual report. And it's not often you're presented with the choice of Sergio Leone or Spike Lee as your film director of choice in the title for a report. So really excellent there. I really just wanted to explore a bit further, and I wanted to use as specific examples. Tim's accepted an invite to come to the next Health and Social Care Committee and maybe do a little bit more on public health. And my question was really that, Tim, is really just to get an understanding of how we as a board are actually using your public health team's information, data, input in our service planning and delivery. If we are, and I'm sure we are, but as to what extent, and could we do more? And I was looking at specific examples, say, of within the primary care improvement programme of community link workers and their role and how they can actually take us down that social prescribing route and all that entails with that. But I was also thinking of as well about the pharmacotherapy work, which is within the PSIP programme, and how we're actually addressing the negative impacts of opioid damage because of prescribing, because I'm sure we're beginning to see in our treatment and I'm sure in our drug-related deaths, we're seeing the impact of opioid prescribing in there and the unintended consequences which were spoken about there. So I just wanted to get your thoughts on that, Tim, and whether how we're using it and how we could actually do more with it.
Actually, Tim, before I bring you in, can I put my question as well, because it links really strongly with what Jerry's just asked, coming at it from a slightly different angle, but I suspect you'll be able to wrap it up into one answer. So I was, quite excited reading about the social prescribing, and I suppose, you look at the starkness of the inequalities and the health inequalities, and you look at the leading causes of loss of healthy years and how many of those are preventable diseases, ischemic heart disease, lung disease. So that, a real, for both of those reasons, for inequalities and preventable disease and the burden of disease, a reason to focus on that preventative public and population health. And then looking at the positives around social prescribing, I suppose I'm slightly conscious, though, that in pursuing social prescribing, there is a risk that we might further some of those inequalities. And perhaps I'm looking at this a little bit too simplistically, but a lot of, social prescribing being successful depends on a lot of things. And it partly depends on people having access to, and I guess the privilege to pursue some of those. And across our different communities, people will be unable to take full advantage of that for different reasons, whether that is because of their own circumstances or because of the capacity in the community. If they don't have those things in their community for them to access, they can't access them. And then also being very aware of the importance and the benefit that those community link workers can add into social prescribing. But of course, we don't have community link workers everywhere. And there is a question around future funding for community link workers as well. So I suppose what I'm saying is social prescribing offers us a real opportunity to do something preventative and positive and address the whole well-being. But how do we support that as an organisation in a way that doesn't further exacerbate the inequalities, whether that be because of, people are in an area which has got high SIMD factors, or whether it's because of geographical access? Sorry, that was a very big and complicated question, but it tied into what Jerry was asking a little bit, so I thought it was good to throw it all in together. Thanks.
Yeah, thanks. So I'll try and answer Jerry's question a bit first. I think we do make good use of the to demographic and epidemiological information. I mean, as witnessed, for example, by the profiles that have come out. However, there is still a bit of, and it's not peculiar to NHS Highland in any sense at all. It's a little bit of a gap between how we do the planning of services and what we know about the health needs. I guess that comes a little bit down to prioritisation and how we use the information about health to prioritise what we do. There's always a temptation to continue with health services and to continue with what we've done before, and to look at developments as new things rather than changes. When I first came into public health, which is quite a long time ago now, south of the border, one of the questions that I couldn't entirely understand was what was the connection between all these people in public health who were doing the health needs assessment and the people who were in that English model then commissioning the services. And then I realised there wasn't very much connection, and then that the people were doing the things separately. Now, we're not in that position here, but I think there's still a sense of not using all the opportunities that we've got to look at how we prioritise things, and that be by prioritising between prevention and delivery, or prioritising around inequalities, and looking from the prioritisation point of view around use of health economics as well as another tool which we're looking to hopefully we can strengthen. So I think there's the scope both ways really, of being clear around what we definitely want to look at in terms of analysing the needs, but then particularly with the so what around how we use the information to change and modify and prioritise our services. And I think that's apparent both in prevention and in inequalities. And it is difficult to prioritise the inequalities because that means sort of essentially often prioritising services for people who don't use the services at the moment. So there's the opportunity cost there. And so that brings me on a little bit to Sarah's question. And when it comes to social prescribing, I think we do need to remember social prescribing in the round, which will include for people at with poorer incomes, things like benefits advice, and actually helping managing money and helping in moving to employment if people aren't employed. So there's a wide section. It's about, as you said, Sarah, earlier on, and a different item around being in the same storm but in a different boat. And many of the people on the board meeting will remember the idea that we had around building a better boat in terms of looking for social mitigation post-COVID and how we could address that. And that to a large extent is what the social prescribing is about. And we have used that initially within Highland HSCP, where social prescribing came in, was targeted to the areas of deprivation, which is not entirely straightforward, and there will be some people who would need that who'd miss out, but it has recently been extended, but it's still concentrated in areas of social deprivation, and it's being able to target what interventions we have, and most appropriately for the populations that we serve. So I think there's a wide range of interventions that can be put in place, can potentially reduce the need for medication. But I think one of the challenges and also opportunities, and it gets a bit back to the report last year on prevention, is actually to make sure that when we put interventions in place, that they are appropriately evaluated, and that we try and get a reasonably level playing field to say, if we put particular interventions, let's say something around straightforward around smoking, around reducing smoking, that we take it seriously, that we actually do it, and that we monitor what we do monitor what we're implementing and make sure it works. And if you look at the IPQR on smoking, for example, we're not really doing that great at the moment, so we need to turn that round, but we also need to focus on where else we can do that, but as I say, take it seriously in the level playing field with other interventions.
Thanks, Tim. Love that sticky mute button. That's really helpful. I think there's quite a lot in there for us to take away and think about, and not something we can fix in one box. But that's really helpful. Thank you. Okay, I have got Karen and then Brian. So I'll bring you in next, Karen, please.
Thank you, Sarah. And it's a sort of continuing theme, really, and it's not specifically a question for Tim, but more in response to the paper and the note around there's no direct financial implications from the paper, but there are likely financial implications for the system if some of the recommendations are not then considered in some sort of priority. And I think it's more, my thinking was how does it all join together? And again, yourself, Tim, you've mentioned that earlier, that there needs to be some mechanism, I would think, to look at how some of these recommendations sit within the future sustainable health and care system planning, and how that then supports executives with their questions and comments around that redesign piece. because there's really clear evidence from Tim's report about where there are some potential areas for improvement around that kind of financial, that would support potentially financial planning. So I think it was more, how does it fit together? And again, partly that's a question for my own self because of being new to the board. But I think it's a really, I think there's more could be made in that box of financial, because actually there are no direct financial implications from the paper per se, but actually there are system-wide financial implications. So I think that perhaps could be developed further. Thank you.
Thanks, Karen. And then Pam, did you want to come in on that? Yeah.
Yeah, so I think in terms of translation, how do we bring this to life, and how do we make sure that we take the substance of this report and apply it and get some outcomes that match the intent? So absolutely the right question. We have got emerging programmes of work, strategic change programmes, and so internally this report has to be considered in the context of the work streams that are generated, and as you say, what's the benefits realisation and how is this really going to change the system going forward? So that needs to go into that arena. I think the other place that it usually is aired and definitely needs to be considered is in the outcome improvement plans for the community planning partnerships in both health and social care systems, and these reports they get taken through community planning, and again it's about, so what's the so what in that? If this is the kind of information, intelligence, knowledge, evidence base that can take us to a different place, how do we ensure that Tim's report doesn't get a nod and say, oh, that's great, and then we don't use that intelligence to get better outcomes? So there's an internal process in terms of how we're taking forward the redesign, and there's the partnership process. Although the knowledge of this should be cognizant in every bit of business we do, what's the opportunity that we should all as leaders in the exec team be considering in our day-to-day work? So I think that's maybe where the question that both yourself, Karen and Emily, were kind of raising, and therefore the measurement would sit within the success of those programmes, taking cognizance of the content of this report.
Thanks, Pam. Brian is waiting patiently, but Fiona, did you want to come in on this point, or was it something else?
No, it was that one, Chair.
Okay.
Thank you very much. I'm conscious that Pam Cremming gave apologies, so I just wondered if it was useful from a partnership perspective, maybe to talk a bit about not just this report, but the role that public health play in the way that we do our business within the partnerships. Obviously, I'm much more familiar with the current arrangements in Argyll and Bute, but I think it would be safe to say that we wouldn't have made any of the progress we've made in Argyll and Bute without public health being absolutely integral to the way that we think about our population need and our strategy, and then taking a way forward in terms of interpreting what that epidemiological information is telling us, the story, the narrative of that, and turning that into specific action where we actually adjust and change service delivery in line with that information. A really good example that people on the board that have been here a little bit longer may recall is the work that we did on the island of Coll, where we had particular health and social care challenges. It became quite a hotspot for us. And we worked with the community and the community council on Coll through a collaborative working group. But our public health team did a household survey and strategic need assessment of that island, which was a real challenge to micro, if you like, the work that often is done in macro in public health. But it absolutely transformed our ability to have a communication with that community, and to move on the conversation about what the health and care needs over the long term were, and how we might start to address that both as a health and care system, but also with partners around water supply or housing matters or other issues that impact on those social determinants of health. So in our partnership, we will be looking at Tim's report, but also wider public health information that comes in any number of forms. Through our strategic planning group, it's absolutely integral to the work that we do there, that we look down, but then we have to look up and we have to look at the horizon again. And the public health information is often what gets us to lift our head up and look where we're going in the longer term. So, I would commend that each year, you know, Tim brings the report to our local authority as well, so our elected members are very cognizant of these themed reports. I preferred the cover last year because it had a picture of that was right on the border of the two patches on it. But, you know, Tim, our local authority colleagues know about this, you know, our health teams know about it, but the overall role of public health is absolutely integral into the way that we're trying to transform within the partnership and modernise and take forward appropriate services that match need. Thank you.
Thanks, Fiona. That was helpful to get that partnership perspective, absolutely. Apologies, Brian, you've been waiting very patiently. I'll bring you in now.
That's okay. That's okay. I'm actually probably taking us slightly back in time anyway, back to your comments, Sarah, about the sort of the potential for widening inequalities. I have to say I'm really quite excited with growth in the social prescribing in particular, but as Tim will well know, you know, the history of addressing health inequalities is often the story of exacerbating them inadvertently, because so much of the time we try to do something about it and we still get differential uptake, and our interventions are also differentially effective. And but I do think there's an opportunity, if you get the social prescribing right in terms of what it is you are prescribing. And the evidence shows that if you're designing these things in much more of a sort of co-constructive way with communities, actually, I think they're potentially very powerful indeed. There was this is going back a good number of years now. The Scottish Government funded some pilot projects which were really rolling out interventions to address some of these issues. And there was a report which was stemmed from the multiple evaluations which created a whole set of design principles. And to be honest, I think the report is underused on all those design principles. I'm aware of it because I sort of wrote some of them, but so this isn't any form of self-promotion, but I'll pull it out and pass it on to you, Sarah, if you want to pass it on to anybody else. But I have to say, I think the social prescribing, if we can engage with it effectively and have the right things we're prescribing to, it can avoid some of these problems we've had with exacerbating inequalities in the past. I'm very optimistic. It was good to see in Tim's report.
Thank you, Brian. No, absolutely. I think there's significant potential there for us. Like you said, if we make sure that we're utilising that in the right way to actually get the outcomes that we want for our communities and our population, and would much appreciate having sight of that report. It sounds very interesting. Okay, good. Right. No further hands up I'm seeing. I'll just check there. So we are being asked to note that annual report, and just to echo comments from others, Tim, thank you very much to yourself and your colleagues who've put work into that. It's a fantastic report and adds to the suite of previous reports that we have, which I think are really important to the work that we're doing, and a very interesting read as well. It's good. So thank you very much. Colleagues, I realise that we are running quite a bit behind time, but we're having some really good discussions, so we'll just, you know, I'll hold my hands up. Poor timekeeping today, but I think it's all good stuff. Right, that takes us on to an item I'm going to ask Boyd to speak to. So this is item number 6, and this is our corporate risk register. So Boyd, I'll hand over to you.
Thank you, Chair. Hopefully I can assist with a little catch up. As a routine, we present our updated risk register, which is a dynamic document, varies a little bit from meeting to meeting. And there have been some small changes and also some mention in the paper of likely forthcoming risks that will be added to the register. It's part of our ongoing work at the top board level of the organisation, which links with other work that's happening in the operational side of things. A last comment from me is that we will continue in 24 to look at how we can better align this strategic risk register with the likes of our Together We Care strategy, and also with where relevant, the ADP. and we are currently at Clinical Governance Committee working on bringing in some expression of clinical risk, so that that is expressed at a high level in this document as we go forward in 24. So in the interest of brevity, I'll stop there and allow any questions. Thanks.
Thank you, Boyd. And of course, we see the risk register on a regular basis in our committees, which is really, really helpful. But happy to take questions. Alex, I will bring you in, please.
Thanks very much, Chair. Yeah, thanks, Boyd. I like it. I like the way it's presented. A couple of suggestions to improve things slightly, and then one question. The scores that are presented, I'm assuming they are post-mitigation scores. In other words, whatever we've done to the risk, that's what the score is today. What sometimes is useful to see is what was the unmitigated risk score. Then we can compare that to what has happened to that score because we've done something to mitigate it. But then also, if we can get an indication of, is that score continuing to fall, or is it slightly going up because something's happened? So for example, on the fire compartmentation one, risk 712, score 16, but in the narrative it says we don't know if we're going to get funding to continue to do any more with it. Now I'm assuming we will find that funding, but we don't know that. So is that score risk liable to go back up, or is it liable to stay the same, or whatever? So it's just a way of working through it. And on that, Richard, have we actually got funding for the fire compartmentalisation issue, or is that still something that we're working through? Thanks.
Yeah, I think Richard, Chair, it looks like people are going to respond to that. I think both Lorraine and Richard are replying to that.
Yep, that's absolutely fine. Lorraine, you wanted to come in?
Yeah, it's a really good point, Alex, and we need to understand as well what's the lowest score we'll be able to tolerate, you know, as a board, and what impact it will have. So I have got a format, as you know, because I like a wee format, that will display that. And I think just as we bring in new risks, it's really important to understand the dates that will take effect and then what that will do to the score. So absolutely aligned with that, and I'll reflect on that for next time. Thanks.
Thanks, Lorraine. I'm sure we look forward to seeing, we enjoy your format, so that will be good. Look forward to that coming. Richard, I'll bring you in, please.
Yeah, Alex, yes, we're getting the funding for the fire prevention works. We class that as committed funding due to the nature of the improvement notices.
Thank you, Richard. Emily, I'll bring you in next, please.
Thank you, and thanks, Boyd. I think we've previously talked about this at clinical governance, but I just wanted to understand how the codependency between some of the risks might be captured, just because the combined impact of some of them, because of the relationships between them, might be greater than the individual ratings would suggest, particularly the risks around, I think it's 959 on COVID and 715 on vaccine uptake, I think, or the other way around, but just the fact that if the vaccine uptake is lower, then the long-term impact of COVID on the community and general public health is likely to be higher. So although those two might be going down in terms of their individual ratings, they will interact with each other and could potentially cause each other to increase in severity.
Yeah, we'll note that the difficulty is sometimes the science on that particular topic, especially with one eye on COVID, is it's changing rapidly. Without being too specific, we're beginning to see some research that was done, for instance, on medication to do with COVID, which was done on unvaccinated population. But now, of course, we don't know about the medication because now the population is pretty well all to some extent vaccinated. So already the sands beneath our feet have moved, and so that's a good example of where there are lots of variables, and we just have to keep adapting as knowledge and understanding and other factors develop. But thanks. It's in principle, I think it's a really important point.
Yeah, absolutely. And I don't know, maybe as this evolves and as Lorraine's format comes in and helps us articulate some of the other elements a bit better, that might be something that we can build in, because I think you're right, Emily, there's something about looking at the codependencies and the risk profile in the round, and not just each risk individually. It's complicated, but I think we can give it a try.
Chair, if we come back a little bit to the scoring of risks, that's a subjective thing, and in a way, and Alec will know this and others, the danger is to concentrate on the number, but the number is just a way of settling on a final sort of summary position of what are a huge number of factors that will affect the subjective process of scoring. Without that discussion and consideration, without looking at all of the strands, producing a number on its own is quite a dangerous thing. The number is there as a final representation of roughly where you think you are in on balance. But it's for all of us to remember, at all levels of the organisation, remember that the score is the last thing, and it's not the determinant. It's not it has to be all the other stuff that feeds you to a final agreed position. And sometimes the score is about a collection of differing views coming round some single agreed position. And there are processes to help scoring to make it a little bit more objective, but it's always finally a subjective process. And so although the comments I think made are absolutely valid and there are things that we can do, it's sometimes the other stuff feeding into it is the most important, and making sure you have that captured in appropriate places.
Okay, thank you, Boyd. Not seeing any other questions or comments for Boyd. Obviously taking into account that Lorraine said we'd take that, some of that away and have a little look, and we'll get that back in due course, and of course through the different committees we will see that as well. So I'll just check in with everybody. We were being asked to examine and consider the evidence provided and agree the updates that have been proposed, obviously taking into account what we've said about taking some of that away and just looking at the detail as requested. And it's been proposed that we take substantial assurance from that risk register. Are members happy with that? Great. Okay, super. So that takes us on to item number 7. So this is our Blueprint for Good Governance 6-monthly update. So this is myself and Ruth are going to be giving you an update on this one. Members will have read the paper. We're not proposing to go through the action plan in detail. There's various places where we're looking at this, and obviously some of the detail on that action plan is quite specific and operational, so it's not that we need to go through that finer detail, but it's important that the board has oversight and assurance of the work that's taking place around improving our governance. Just to remind people, and perhaps for new members' information, NHS Highland really piloted this approach. So when the Blueprint for Good Governance was refreshed, alongside that was a desire to enable boards to reflect on their governance against that new blueprint and look for improvement actions. And NHS Highland, we stuck our hand up and said that we would give it a try. So we had the opportunity to pilot that, and it was a really helpful experience, and it was facilitated, and we went through that process, and it was a very intensive process, and that then helped us to produce this plan. And I'm very pleased to say that process which we trialed is now been kind of tidied up and rolled out across all the other boards in Scotland. So we're in a good place that we got to do that first, I guess, and that the learning from our experience is now being used to help support other boards to go through that as well. I probably won't say too much more. I'll hand over, Ruth, you can take us through the kind of the nuts and bolts of it and just say a little bit maybe about the governance of the plan and how we're progressing. If that's all right, Ruth, I'll hand over to you.
Okay, yep, thank you. That's fine. So yes, you'll remember we agreed the improvement plan in July last year. So this is the very first 6-month update to the board, and yet it was considered informally through your governance committees in November, December last year. There are 17 actions in total, of which 12 were allocated a target timeframe of 31st December. And of those 12, we're quite confident to suggest that 8 of them have been completed in total. And there's been significant progress on the remaining 4. So, like Sarah said, the report does set out in detail the progress against each of the improvement actions, and the Excel spreadsheet is colour-coded, so you can get a sense at a glance of where the greens are and where the ambers are. Just referencing the comment Sarah made there about the national picture. Other boards undertook their surveys towards the end of 2023, and NES managed that process for them. The blueprint evaluation surveys should be undertaken every 2 years by boards. So while we are ahead of other boards, it's expected that we will join in when NES repeat that exercise again towards the end of 2025. So we will continue to review progress against our existing improvement plan up until that point, until it might be refreshed at that point. And of course, we will put this through your governance committees on an informal basis. So the report also refers to something called frugal governance, which is an approach that supports the reduction and more efficient use of committee time. So governance committee chairs have considered this at their chairs meeting in January, and it's something that we're going to be looking into, and we will obviously bring more information back to you as soon as we can. So the board's asked to take substantial assurance from progress that's currently being made, and that substantial assurance has been identified on the basis that we do have a robust framework of control in place, and that there has been significant progress evidenced against the agreed actions. There will be informal oversight of progress through your governance committees in May this year, and then there will be another formal update at the end of July to this board. Okay, thank you.
Thanks, Ruth. Does anybody have any questions or comments? Again, appreciate lots of people have seen this in other places at different stages of its life, and really just the important thing was to bring it here to give board assurance that work is progressing on it, sometimes behind the scenes, but it is ploughing ahead. Jerry.
Thank you, Sarah. It really, well, maybe a small point. It's just in relation to Action 17 and the proposal to mark it as complete. I'm not aware that a decision has been made on the rollout of care opinion, and it seems rather fundamental to me that that decision has got to be made before we should be marking the action as complete. I appreciate that the report is probably in the process of getting worked through, but I think I would have thought until we whoever is going to make the decision on the rollout of care opinion, until that decision is made, and it may well be is already made, I think maybe that should be left open.
That's a fair challenge. I don't know who wants to pick that one up, or if we just want to make an amendment to keep that open until we've had a chance to, as Jerry said, just check where we are with that decision-making process. I think best thing we'll do, Jez, we'll uncomplete it and we'll double check the detail, and then we can pick that up when we look at it again. Okay. Any other questions or comments on that? No, okay, good. I suppose I would just like to say thank you to everybody that's putting the work in. I know EDG do work on this in the background, and Ruth and her team, and everybody who's keeping an eye on this. That, you know, what one action plan in a sea of action plans. So I appreciate that we keep moving forward on this one. It's really important, and I think there's some interesting stuff that we'll be able to pick out of the frugal governance concept that we can apply as well. So that we're we are being as efficient and effective with our governance as possible. Okay, so we were being asked to note that informal oversight of progress of delivery of the improvement plan will be undertaken by the chairs group and the committees, and note that further progress will come to the board in July 2024, and we are proposing substantial assurance around this one. Are members content with that? Lovely. Okay, so that takes us on to item number 8, and this is a review of our committee memberships. Again, this is a double up between myself and Ruth. People will have read that. It's obviously changes as a result of our new board members joining us, which is very happy news for us. And just to make the changes to our committees, putting our new members into the various committees where we had some gaps, or I was backfilling some of those places. I'm very pleased about this. And just also to pick up, you'll notice there's one which is maybe slightly odd in that it wasn't filling a gap, is that I have asked Emily to shadow on audit, and that's really recognising that we need to strengthen and keep, you know, some continuity around our audit capability. There are going to be some changes coming up this year in terms of membership, and it's just really to give us the opportunity to you know, keep that continuity going. So I think that's a really fantastic opportunity for us. Ruth, is there anything that I've missed? No? Happy to take any questions or comments, but this should be just a fairly straightforward approval if everyone's happy to do that. Great, we have agreement there. So we come now on to our governance and committee assurance reports. I will just fire through, and as per usual, we take the minutes as read. I will ask each chair just to pull out any highlights or areas of concern, or indeed areas of good practice, and then we will have the opportunity for other people to ask questions. We don't have Gaynor here, but actually, are we okay? No, that's okay. Right. So first up, FRP, and given the increased frequency of our FRP meetings, we've got 2 sets of minutes, so the 8th and the 5th. And Alex, I'll just see if there's anything you want to pull out there.
No, nothing really, sir. Obviously, the finance position is the one that we've taken an awful lot of time and effort over, and I think it's we should thank the finance team, the whole EDG, and the amount of work and effort that's going in to try to improve the situation. I'm not particularly good, I know, but it's getting better. We've also looked at the report from the environmental and sustainability stuff, and that's still carrying on. Obviously, now the major projects part will take a little bit of a backward step, because clearly the funding for that is no longer going to be available. But we'll still want to see things coming through in terms of design, etc., and what's happening with that. So I'll leave it there and look for questions for either of those set of minutes. Thanks.
Thank you, Alex. Any questions or comments there for FRP? No? Okay. And again, just to reiterate something I'd said earlier on, I would encourage members, if you I know time is always a challenge, but if people do have the time to go along to FRP, it's a really good opportunity, because it's where we do the really detailed scrutiny of the finance piece, which is obviously going to be really critical over the next little while. So that opportunity, and that's true for all of our committees. So yes, Alex, sorry.
So yeah, I was going to remind me, the next meeting's the 9th of February. It's always a sort of 9:30 start, up to somewhere between 11:30, 12 o'clock. So yeah, all people welcome to come along and see, and if you want to contribute, that's fine too. Thank you.
Thank you, Alex, that's appreciated. Okay, let's move on then. So we have the Highland Health and Social Care Committee draft minute of the 17th of January. Jerry, I'll invite you in, please.
Thank you, Sarah. Yeah, as you say, I had a meeting a couple of weeks ago, first of the new calendar year, but as we approach the end of this year, we welcomed a new lay member to her first meeting, Diane van Rutenburg, and who I think actually will be an excellent addition to the committee. Probably just a couple of things just to note. We took the quality review framework, which we had looked at as a board, a couple of meetings together, and we had really good discussions about how we apply that in a health and care setting. Louise came along and really gave us some really lots of food for thought there, and we were delighted to look at the now approved joint strategy for adult social care moving forward, which was really excellent. So those are the major issues, major highlights, I think, of the committee. Happy to take any questions.
Thanks, Jerry. And yeah, absolutely right to highlight that. It's a really significant point for us in the partnership. So thank you for drawing our attention to that. Any questions or comments for Jerry? No? Okay, thank you, Jerry. Let's move on now to our Clinical Governance Committee, and we have a draft minute from the 18th of January, and I will invite Alistair in, please.
Yeah, thank you, Sarah. The points I was going to raise, I raised under the IPQR and were discussed also in Pam's update first thing this morning. So I've got nothing else to raise.
Thank you, Alistair. Yeah, we gave that some good discussion earlier. Any questions or comments with regards to clinical governance? No, okay, thank you, Alistair. We have the Area Clinical Forum draft minute from the 11th of January. I don't actually know, is Katrina, let me just check. Are you with us, Katrina?
Katrina's
not here. No,
Katrina's
she's not,
an apology for today's meeting.
That's fine. I'm happy if people do have questions or comments, we can do it now and we can take that away if we need to. No, okay. Nothing there for Katrina. Obviously, you can also feel free to pick things up with Katrina out with. I'm sure she'd be happy to answer any questions. We have the Staff Governance Committee draft minute of the 16th of January. Again, we don't have Anne with us, but I'm happy to record any questions. Oh, Philip, excellent. You've got your hand up.
Yeah, just as Vice Chair, we don't have anything to raise to the board. We've got nothing that needs referred. But there were comments made earlier in the board meeting about the statutory mandatory training. So it's just to give reassurance that that is coming through staff governance. We've been cited on the arrangements that Gareth has put in place for an action plan there, and we'll be keeping a close monitoring eye on that for the future.
Thank you, Philip. Any questions for Philip? Any comments? No. Okay, thank you, Philip. And then we have the Argyll and Bute IJB, and that was on the 29th of November. Graham, I'll invite you in, please.
Yes, it was a couple of months ago. Our next meeting's tomorrow, so it's it feels a long time ago. Nothing to add.
Thanks, Graham. Yeah, it's always a bit out of sync for the IJB, isn't it? It's always pretty much the day after, so it's a bit of a lag. That's great. Any questions or anything for Graham? No. Okay, that's great. So we were being asked to note the minutes and various actions from Aerial Clinical Forum and the IJB, and obviously noting those on the minutes as well, and confirm that adequate assurance has been provided from our board governance committees. Are people happy to do that? Yeah, I'm getting thumbs up. Okay. So do we have any other competent business that needs to be raised? Not seeing any other hands up there. So that brings us to the end of our agenda. Thank you very much, everybody, for your time today. Bizarrely, we made all that time back up and we're closing on time. I'll take all the credit. No. Thank you, everyone. It was a really good discussion. I think it was a short agenda, but we covered some really important stuff. And I really appreciate all the engagement that we've had today. It's a great way to start off 2024 with lots of challenge and questions, which is absolutely required. So our next board meeting is on the 26th of March at 9:30. We'll stop the meeting there, and if we want to switch off recording, and then we can just do a bit of agreement about what we want to do with in committee. Thank you.